A motor system examination is one of the toughest examinations to master, and you'll find that many people can actually perform it or they are able to do the different maneuvers, but afterwards unable to come up with very good differentials for whatever they have found. And this is because it comes from the motor exam is closely associated with the nervous system and understanding the relationship between the upper motor neurons, the lower motor neurons, different conditions and different diseases that are in very difficult fields like neurology. But when you understand the theories behind it, sometimes it becomes easier to understand and remember, and even things make more sense to go on, and the order will come well. So if you're new here, welcome to MedFunPager. My name is Benjamin and I make these rapid revision videos with a one-page summary where I look at particular very interesting and high-yield topics. So like all other examinations that we have done in this Hutchison series, when we're doing the motor system examination, we're going to begin with the general inspection or the general examination. And what you're going to look for when you're doing a motor exam is that you're going to look at the patient before you actually touch them, and you're going to observe the position the patient is sitting in the bed or in the chair. Are they lying down? The ease with which they make their movements. Sometimes are they restricted? And do they not want to move? Are they using walking aids or sprints? They could be around the bed. They could have clutches around the bed. They could have a wheelchair around the bed. And then you want to see their posture. You want to see, is it a normal posture or is it abnormal? Do they have flexed arms, extended legs? Sometimes things like that. You know, you have the things like a decerebrate or decorticate postures, where the decerebrate is going to appear in certain way that is different from the decorticate. Let me leave that one out. I don't want to cause a lot of confusion at the beginning. So sometimes they are having a floppy limb, and floppy limbs are going to be signs of lower motor neuron lesions. Then we look at the muscle bulk. Now, the muscle bulk, it's important that you compare both the right and the left. Some people are naturally, they are smaller compared to the others. So it wouldn't be fair to compare the muscle bulk of one person to another. But when you compare the left and right side of the body, we try to think the body tries at least to be as symmetrical as possible, or the asymmetry is not going to be too big. So when I look at the muscle bulk, you're going to look for muscle wasting. The thin muscles you're going to use for muscle enlargement, that is pseudo-hypertrophy, and that could be caused by some things. And you are going to commonly check these places for hypertrophy or for wasting. That's going to be the thinner and the hypothenor eminence, that is in the hand, the interossei muscles, the deltoids, and the quadriceps. Then you're going to look for involuntary movement. Sometimes patients are having fastulations, and these are the fine muscle twitchings. You find someone is there having a twitch, and they also could have tremors, and sometimes you have like a resting tremor. In Parkinson's, you can have an action tremor in cerebellar conditions. Then after you have looked at the patient, you have observed them carefully, then you can move on to the tone. And the tone is the resistance that you feel when you try to passively move a relaxed limb. So how you're going to perform it, you're going to ask this patient to relax, and when they are relaxed, you're going to support the limb entirely. You don't want the patient holding the limb by themselves. So you want to rest if it's the hand, you want to rest the hand on your arm, and then you want to move the joints slowly and then quickly. You're going to do both, and then you compare on both sides. So what happens is that if they're having an increased tone on one side, or if they're having an increased tone, you're going to see about two patterns. They're either going to have spasticity or they're going to have rigidity. Now, spasticity is kind of rigidity that lets go. They're going to be rigid, then they're going to release. And that is going to be commonly seen in upper motor neuron lesions, where it is velocity dependent. So imagine this patient's arm, you're trying to maybe extend the arm. When you try to extend it very fast, you're going to feel some sudden resistance, which will eventually let go. And that's going to give a clasp knife a feeling. If you look at the picture of a clasp knife, there, imagine that you're opening that knife. At first, you're going to feel great resistance, but towards the end, it's just going to then let go and open up easily. Then when it's the rigidity, when the tone is increased and we have rigidity, like in Parkinson's disease, sometimes we have a constant resistance, and we shall have either a lead pipe or a cogwheel rigidity. Now, a lead pipe, when you look at a lead pipe, it's solid, and when you try to bend it, the way you would imagine how it would feel when you're trying to bend that pipe, imagine your patient is made up of pipe, and then you're trying to bend, it would be really very hard. And the cogwheel is a wheel with these different cogs on it. So imagine trying to move it on the ground, the way it goes on cramping, letting go, holding, letting go, holding, letting go. That is the cogwheel rigidity. Then we have decreased tone, and decreased tone is mostly going to be seen in lower motor neuron lesions. Sometimes when you have spinal cord injury early in the onset of spinal cord injury, you're going to have a decreased tone, and it is going to resemble that in lower motor neuron lesions. But actually, it will eventually evolve. So when we have a decreased tone, like a floppy limb, we're going to see this in lower motor neuron lesions as well as acute stroke. Remember, stroke is going to occur in the central nervous system, but it's going to resemble that of the lower motor neuron lesions, like in polio or things like that. Then we have muscle diseases. They're also going to cause a decreased tone, like when you look at Duchenne's muscular dystrophy and things like that. Then when we look at the power, we're going to look at the muscle strength, and the key points is that we're going to test it against resistance. We're going to encourage the patient, and then we want to make sure that you compare the sides at all times. You will find someone is weaker than you or weaker than you expect, but their power could be more reduced on one side than the other. So you always have to compare with the patient's other side and want your own strength or another person's strength. So we're going to grade the power, and this is how you would. So if there is no movement, the patient can't really move the arm, then you'll say no movement. You are going to grade them as power 0. Then if they have a flicker or they can move the arm a bit, then that's grade 1. If they can move with gravity eliminated, that is horizontally. If they are lying down, they should be able to move it from side to side. That is grade 2. If they can move it up against gravity, then that's grade 3. And then if they can move it against resistance, that is grade 4. And if they can move it against if they feel like they have normal power, then you are going to give them a grade 5. And this is how you're going to test for the power. So in the upper limb, you always want to test the power coming from proximal to distal. You want to test the power nearest to the body as you go out from the body. And this is very important. So with the upper limb, you're going to begin at the shoulder. You want to see, can they abduct the shoulder? You want to tell them to pull their hands away from the body. That is shoulder abduction. Then after the shoulders, you're going to go to the elbows, the next joints distally. You're going to do elbow flexion and extension. And then you want to test the wrist. And after the wrist, you want to test the finger grip. You want them to grip onto something. Then you want to test finger abduction. Can they fan out their fingers? And then you want to test thumb opposition. You could actually put your thumb against theirs and ask them to push, or you hold the thumb backward and tell them to pull it. That is thumb opposition. Then the lower limb, you're going to do hip flexion first. Remember, again, we're beginning from near that is hip flexion. Then knee extension, where they extend the knee, then knee flexion. You go to the ankle, you go ankle dorsiflexion and ankle plantar flexion. And that is how you test the power. So the patterns to recognize is that if we have proximal weakness, if the muscles that are proximal to the body are weak, most of the time that is a muscle disease. And if we have distal weakness where the power at the end of the limb is the one that is affected, is going to be in the nerve disease. For example, in kids who have Duchenne muscular dystrophy, you may find that their thighs muscles are weak. So when you ask them to stand up, they can't actually just do that. They cannot stand up easily because the thighs are weak. So they end up supporting the thighs with the arms, and they use their arms to actually stand up. And that is what they call the grower's sign, which is most commonly seen in people who have Duchenne's muscular dystrophy or other muscular dystrophies. Then when you have things like common nerve injury and someone develops a foot drop, you'll realize that it's the distal muscle that is affected. So most times, if it's the distal weakness, it's a nerve issue. If it's a proximal weakness, consider a muscle disease. Then one-sided weakness is going to, most of the time, point to a stroke. Then we want to go to the next portion of this motor system exam, and that is the reflexes. And this is very important. So the reflexes, we're going to test different nerve roots. We'll have the biceps reflex, where you hit the biceps tendon. and C, contraction of the muscle. Now, the most thing that most people have is that when they tap the tendon with the patellar hammer, they wait for the movement of the arm. But actually, most of the time, you have to just look at the muscle and see it contracting slightly when you tap it. So when you test the biceps, it's going to be C5, C6, the triceps, C7, C8. Then the supinator muscle is going to give you C5 and C6 too. And it's a supinator reflex. And when you look at the knee is going to be for L3 and L4, and the ankle is going to be testing for S1. So when the reflexes are there, you're going to grade them. If it's absent, you give 0. If it's reduced, +1. If it's normal, +2. If it's brisk, +3. And if there is clonus, that's +4. Now, clonus is this jerking, exaggerated jerking of the muscle after trying to elicit a reflex. Then we go to coordination. Now, coordination is important that you only do it if the power is adequate. You don't want to find a patient who is down, who is very weak, who can barely move, and you want them to stand maybe and do a heel to shin test and test their coordination. So upper limb, if their power permits, you want to do the finger to nose test, where you tell the patient to point your finger and then to their nose, and they do it in rapid movements, and you see if they have abnormal findings. This could point to cerebellar disease, because it's the cerebellum that is important for coordination. Then the lower limb, you want them to try out the heel to shin, where they put their heel onto their shin. And then if you find still abnormal findings, that's going to point to cerebellar disease. Now, when we go back to the reflex a little bit, I skipped out on this. We have the superficial reflexes, and that is the abdominal reflex as well as the plantar reflex on top of the muscle reflexes that we saw above. And then the plantar reflex is one important one. And normally when you cut kind of a filament, or it's normally a monofilament that you're going to pass on the patient's foot, starting from down, going towards the little toe or the small toe, and then horizontally to the right toe. Most of the time, the response is that the toes are going to move downwards. But when we have upper motor neuron lesions, the toe is going to actually go upwards, and that is what we call the Babinski sign, or the positive Babinski sign. It's mostly going to point to an upper motor neuron lesion. That is like things like stroke. But it's important to know that in children who are young, most of the time, they are going to have a positive Babinski, and it's normal because the brain has not well developed. So for them, they may actually fan outwards, or the big toe will go up. That is a positive Babinski, and it's a normal finding in children. Then we have a sensory screening, or we have the gait. Let's go to the gait first, where you want to make sure you observe the patient, how they are walking. When they're walking, onto their speed, their balance, their arm swing, and their step length. That is very important. Sometimes the speed, they can balance maybe poor if they have cerebellar issues. The arm swing, patients with Parkinson's tend to be rigid a bit. And then the step length, they have very short steps, which is a short stepping gait. So that is, or a shuffling gait. That is commonly seen in Parkinson's. Then the most common gaits that we have a spastic gait, we have a hemiplegic gait, we have a Parkinsonian gait, and a waddling gait. And it's very important that you check out these. Maybe you try and look out for features on how these gaits really look like, so that you can always identify them when a patient comes in with them. Then we have sensory screening, where you want to test the patient's light touch. And sensory screening is actually a brief in the motor exam, but you want to test for the light touch of a patient. We are going to go area by area, comparing on both sides. Probably ask the patient to close their eyes, and then you touch them with something light, maybe a piece of cotton, and I tell you when they feel it, and you compare on both sides and see if there is a point on when they don't actually feel this. Then you want to test the pain and the vibratory sense with a tuning fork if needed. And this is going to help localize lesions, especially when we have like spinal cord lesions. We can have different manifestations from it. Now, if you do not know how to understand how to localize spinal cord lesions, I made a video about that in my internal medicine and general surgery, playlist. You can check that out. Then you have the lower motor and the upper motor neuron differences at last. And we want to know this because most of the time, the patient you're going to examine are going to have either one of these a lot of the times. Maybe they are stroke patients, maybe they're having something else. So when you look at the upper motor neuron lesions and lower motor neuron lesions in terms of tone, in upper motor neuron lesions, we're going to have increased tone. That means when you try to check, the patient's going to be spastic or rigid, while in motor they're going to be flaccid. Then the power is going to be reduced in upper motor neuron lesions, and it's also going to be reduced as well in the lower motor neuron lesions. When you look at the reflexes, they're going to be increased in upper motor neuron lesions and reduced in lower motor neuron lesions. Then when you look at the wasting is there's mild wasting in upper motor neuron lesions, but in lower motor neuron lesions, wasting is going to be marked, and that is because the nerve is required to maintain actually the bulk. Innervation is a cause of atrophy in muscles. Then fasciculations are going to be absent in upper motor neuron lesions, whereas in lower motor neuron lesions you're going to have fasciculations. Then when they do the plantar reflex, it's going to be upgoing, which is a positive Babinski sign in upper motor neuron lesions, while it's going to be normal in the lower motor neuron lesions. So we have come to the end of this video. If you're new here, please do subscribe to the channel so that you don't miss out on any other subsequent videos from this Hutchison series. I made 2 videos, one about the general examinations and the respiratory system examinations. Please do check them out if you have not seen them. And don't forget to subscribe to the channel, leave a comment, leave a like. Let's see you in the next one.